ela é professora de nefrologia intensiva e medicina interna lá na Universidade em Monterrey, no México. E ela vai falar sobre hemoadsorção no cenário de terapia intensiva. Uma aula muito interessante, né, para a gente ter contato com essa nova terapia. Ela vai explicar para a gente como funciona e também indicações e apresentar alguns casos clínicos. É uma sessão de 40 minutos. E vai ter tempo também para a gente fazer algumas perguntas para a professora. E é uma maneira da gente, né, entender, né, porque pode ser o nosso próximo passo aí dentro da terapia intensiva. Então é bom sempre a gente saber como essas novas terapias funcionam. Esperar mais um minutinho, né, como de costume, a gente começa geralmente uns 5 minutos depois das 7 e deixar o pessoal vir chegando aqui. E pedir para vocês, né, deixarem sempre o microfone, o áudio ali no mudo. O chat, né, a gente incentiva vocês, se vocês tiverem algum comentário, ou até se vocês precisarem que a gente traduza alguma parte que não ficou claro, assim, deixa no chat que a gente vai comentando com vocês. E no final da apresentação, eu queria que ficasse reservado mais para perguntas mesmo, para a gente ter um debate. Tá joia? Então, mais um minutinho a gente começa essa sessão.
Can I share my screen now?
Oh, yeah, definitely. You can put it on the...
I don't know if you're already seeing it.
Yep, starting to share right now. Yep.
Yeah, you're seeing? Yeah. Now, let me see. Now?
Mm-hmm. Yep,
Perfect.
I can hear your presentation. I think you can get started, Lília, and thank you so much for accepting our invitation here for us in DaVita, Brazil. Welcome to Brazil, even virtually. I'm glad to hear that you're gonna come here for the Brazilian Nephrology Conference this month in my hometown of Salvador. So I really hope you enjoy your time here, and thank you for enlightening us with your talk right now. And I hope to see you here in Salvador as well. I'll definitely be in the room for your chat as well. So welcome.
Thank you. Thank you for the invitation. I am really happy to share with you our experience and also to be the next week with you at Brazil, but this is in advance what we are going to talk about. Hemoadsorption is a really new frontier, but concepts are not new. So we will follow through this story, this part of that. So I'm sorry. Okay, yeah. I'm from Mexico, in the north of Mexico. Usually you think from Mexico City, but this is far from Mexico City. It's in the north, very near from the United States. So I work for two different kind of hospitals. We have a university hospital, this one, and I have nephrology fellows here. And this is a private hospital where I have internal medicine fellows. So we will see cases and pictures from both hospitals, but definitely different scenarios because we have different kind of patients. This is my disclosure. This invitation is from definitely. This will be the session pathway. We will talk about critical care, AKI, and blood purification concepts, cartridge, the anatomy of a new opportunity, proposal of cartridge indications, our experience, and some conclusions. For studying, we will have the critical care nephrology. That this is an emerging specialty, and it focuses on the management of AKI and renal complication in critically ill patients. We wrote this editorial from blood purification in order to understand what means critical care at this moment, because it will be perfect equilibrium between effectiveness and experience and quality of care and safety first between the doctors, healthcare physicians, and the environment of hospitals and healthcare, society, or economics. So it will be kind of difficult to maintain this equilibrium, and it will be very nice if we can work together as a multidisciplinary care of team. Also because of ICU patients needs a very strong communication and encourage everybody to talk the same language and understand what we are going to do if we are going to perform a new therapy. Can I ask for somebody to shut the phone, the microphone, because it's open?
Pessoal, tem pessoal com o microfone aberto aí. Por favor, se puder fechar o microfone, agradeço. Obrigado.
Okay, so the incidence of AKI is rising, so we are trying to optimize patient outcomes, even if all clinical trials that has been performed didn't show any less morbidity and mortality. Instead, we have increased morbidity and mortality, and we should follow and try to find a way to go better. So for us, the critical care nephrology is that combination with a higher interaction between the kidney specialists, in this case nephrologists, and the critical care medicine, that in this case is ICU. So in order to have a better understanding of severity of illness and try to make strong and together forces to fight against our common enemies. So the importance of the teamwork is because we need to go in a continuum all together, especially when we fight against maybe sepsis, is one of the most common scenarios. Also, if this combination have AKI, fluid overload, or dog adjustment. So the critical ill patients who will receive kidney replacement therapy or renal replacement therapy in ICU needs a coordination of care between nephrologists, intensivists, nurses, pharmacists, nutritionists, physical and occupational therapists, between others. So it's a interprofessional care and teamwork in the ICU. For us, maybe the strong bond is between critical care nurse and nephrologist, because any renal replacement therapy that you want to perform needs then a special nurse to connect the renal therapy. So a new thing in these therapies about hemoadsorption, it has been a very new performance and bonding with the people from pharmacies, because we need a coordination about the dynamic of turns of antimicrobial agents. This is more stronger from sepsis, because if we are going to have a clearance in CRT, maybe with you add hemoadsorption, you will have more clearance. So we will need to increase the dose of antimicrobials or antibiotics. So it's important to talk with them, and if it's possible to measure some values, like in vancomycin, it's better to measure values every time we have. So for starting how it works for us, for the first part, we would like to start from the beginning, not at the end of the treatment when they call us only for initial renal replacement therapy. For us, it would be better if we can go through this indication from the beginning when we recognize AKI. And also we have been trying to find ways to start an early attention between biomarkers and electronics alert that trigger the activation of the nephrology rapid response teams. Also, we are trying with different biomarkers. One of the most accepted one with the FDA permission in USA, it's NephroCheck. So we have been trying to perform some flow charts to start the call from the nephrology rapid response team. So through history from 1950 to 1926, we have been developing different conceptual models. So AKI is different from a clinical, only from a clinical call to molecular call. But the most important thing is to call a team and kidney experts. So we are trying to move forward to have a group of nephrologists that from passive to proactive. That makes maybe a difference and could be Santo Grial, we'd say in Spanish, for make a better performance in mortality. So if you see this review from the Critical Care Future in 2017, we thought that we could be at this time making multi-organ support, but definitely COVID-19 era make us to work this earlier and faster. So we performs a lot of multi-organ support therapy in CRT combinations from AKI in COVID-19 till now. So also we wrote some papers from Latin America to see which possibilities we had. And even in this time, in 2020, we already talk about adsorbents, but it's not new. Also, Professor Ronco talked about the adsorbents in combination with other therapies, and we repropose again the call for critical care nephrology to work together, because most of these therapies, even if there is no AKI, could be performance in CRT technology. So for us, now at this date, we have also AI, artificial intelligence, and has been very interesting for us to call and trigger again a different way of nephrology rapid response teams in order to see how the patients arrives, but also how the patients goes around ICU, combining the clinical, the biomarkers, the POCUS, and also all the interventions we can offer. So this is a new proposal from AKI. It has been published this month. And now we are seeing this evolution from critical care nephrology, from this rise of teamwork and extracorporeal support. So now nephrologists should know more than only renal replacement therapy. We know more than extracorporeal organ support. But most recently, we have been converting in experts about blood purification critical care team. So we are trying to help the other specialties, first of all, ICU healthcare people, to make an understanding from this multidisciplinary teamwork and this individualization of the techniques and treatments about blood purification. What is blood purification really? This is the new development of this testing of extracorporeal blood purification therapies that constitute a novel area in which critical care nephrology are involved, using devices from immunomodulation, mitigation of inflammation by removal endotoxic or cytokines, and direct pathogen removal from blood. So we are trying to make an equilibrium from dams and pumps in order to try to mitigate this cytokine storm. So even if there are a lot of studies underway in patients with sepsis and other critically ill population, there is not at this moment not a very strong study to say that it's a very supported treatment, but under the rationale, it has a future promise for treatment. So, but as I said before, it's not new. The first time they wrote about hemoadsorption, it was 1999. So adsorption like that also talk about the remove of all interleukins, cytokines, and other factors. It has been very strongly studied about sepsis, and this rationale is about that, about trying to have not a very strong response about inflammatory cascade. So sorbents could innovate this situation and try to remove this huge peak about the inflammatory response. In one of our books, this is a manual that we wrote for our SLAN Society and for one of our courses that we have here in Mexico, and it has been this is the fourth generation that we are doing online. We try to put that, the hemoadsorption or adsorption should be decided between the molecules you want to remove. So if you want to remove high weight molecules, you should use absorption or high cutoff membranes. And there is difference between the other modalities in CRT, convection, diffusion, or ultrafiltration, with hemoadsorption that can remove larger molecules. So if you go to this let's say a little all about the difference between the modalities in CRT. We already were talking about hemoadsorption with plasma exchange with a plasma filter and combinations with absorbents, and also hemoperfusion that now with the new nomenclatures become hemoadsorption. So for us, this could be the proposal of the cartridge indication, the hemoadsorption, this blood purification new promise. If we go till now, last year, the nomenclature standardization should propose that talking about the disposables that should go into CRT technology could be divided in filter, plasma filter, or cartridge. In case of hemoadsorption, it should be by membrane or by pearls. So this hemoadsorption that we are going to talk is going to be the sorbent cartridge with pearls. So this is what I'm talking about. And also when we can put it in a circuit, we can put it alone, the sorbent cartridge, or we can perform together with a filter and do different combination of therapies if it's necessary, renal replacement therapy and immunomodulation or other indications. So clinical application of sorbents could be divided in toxicology. Hemoadsorption has been used to treat several types of intoxications, such as paraquat or organ phosphorates, or natural toxins like snakes or scorpions. But it has very unpredictable and uncommon nature in this condition, and there is no control studies. We have another situation with liver disease. There are little data in hemoadsorption for several liver failure. I have some cases, I will show you one, but the report suggests an effect on severe cholestasis, associated with pruritus. This is another possibility to work. And however, hemoadsorption is ineffective and removing ammonia. You can remove ammonia from hemodialysis, even if there is not hemoadsorption. In kidney disease, there is another variety of toxins which accumulate in kidney failure, and it could be not always removed by only dialysis, like B2 microglobulin or solutes like makes the CKD associated pruritus. Also, hemoadsorption can be performed in hemodialysis, in chronic hemodialysis therapies, and could be remove this pruritus. This is my team. As you can see in Hospital Universitario, you can see that we have a different kind of cartridge. This is from liver failure, and we have all this liver failure. This is for sepsis or inflammatory, and we have other kind of cartridge. In sepsis, even if there is not a strong evidence, we try to performance hemoadsorption, we think that in inflammatory cascade we can make any difference. It could be also selective hemoadsorption, like in case of polymyxin B, or non-selective, like in CPVA, cytosorb, and now Jeffron cartridge. Then they now are more selective than before. So we have a rationale with the sequential extracorporeal therapy in sepsis, even if we don't have a very support clinical trial, but we try to control the source and remove endotoxins, try to make some immunomodulation with removal of cytokines, and try to make a multi-organ support therapy with different kind of combinations on removals and blood purification. So we have this kind of at the moment of the at global environment, the possibility to see Seraph 100 that it's in the United States, made from Xtera, Torimixin that it's also for ester, Cytosor from cytosorbents, and from Jafron HI 330, and 380. We have another kind of, but we will see it next, oxides, sepsides, and hemophil, but none of these are available in Latin America. So as we said, if we are trying to remove cytokines without AKI or other indications, like patients that goes on cardiac surgery or organ transplant, it could be possible to remove these cytokines only performance the hemoadsorption, even if we don't have hemodialysis. Also, there are combinations that make very good results. I will show you from plasma exchange in combination with sorbent cartridge. So talking about hemoadsorption, most recently in 2024, it has been also performs an ADKI group that make an opinion and review of literature where they make all the proposals of use of the hemoadsorption. Hemoadsorption needs for B performance, vascular access, and extracorporeal circuit. This extracorporeal circuit sometimes, and most of the time, maybe is a continuous renal replacement therapy, but sometimes it could be performance in other, like ECMO. Most of the time is by sildenafil in case of ECMO, but it could be performance together with citrate. You don't need to change the anticoagulation. And there are several technical options, like direct from blood, and with a blood flow from 100 and 250 if you make an intermittent hemodialysis machine. And you can also integrate this in CRT circuits to remove other molecules than creatinine or ammonia. And also you can make combination from different multi-organ supports and absorption therapies. You will see DPMAS and also combinations like CPVA and others. So when we talk about absorption and a cartridge, we will find this cartridge full of bands or pearls that are a special characteristic that makes possible to remove these large molecules. So absorption is a process of separation of masses by a solid agent. It differs significantly from classical mechanisms such as a convection or diffusion based on separation through a barrier. It's not a dialysis membrane, so it could remove these by modalities beyond the permeability and characteristics of the membrane or other phenomena of the molecular interaction between sorbents, and could be more specific about purification mechanism. Hemoadsorption can overcome the limitation of some dialysis membranes and achieve effective solute removal superior to conventional techniques. So if we open a cartridge, we can see this absorbed bit, and this also have an internal structure that it's different and has a small holes that has also the absorption capacity. So they try to remove this toxin in different scenarios, like drug poisoning, removal cytokines, and moleculars such deep PAMs or DAMs. A sorbent can be in the form of solid granules or spheres with a diameter between 0.5 and 1.2 millimeters. They have a very high surface area, up to 1,200, and they're classified according to size of the pores. Macropores, more than 50, mesopores, 2 to 50, and micropores, less than 2 nanometers. So the modern sorbents are characterized by high selectivity or affinity of solutes, chemical and thermal stability, hardness and mechanical strength, tendency to flow freely through packet spheres, and excellent biocompatibility. This is the way we can see how the anatomical inside cartridge are with these beds. So we can have this interaction interparticle, interphase, or intraphase. When the liquid phase flow, this is blood or plasma, circulates through the solid phase, this is the sorbent or spheres, the removal of some molecules by absorption occur external surface of the spheres, including the internal surface of the structure, that is the pores inside of the pores. This is what we're saying, talking about. So medium large molecules that cannot be removed by diffusion or convection can be effectively removed by absorption on the surface of porous polymer absorbent spheres contained in a cartridge or column. So the efficiency of absorption depends on many factors, such the amount of sorbent, the cartridge design, the blood flow, and concentration of solutes in the blood entering at the cartridge. After a few hours, this concentration of the sorbent at the outlet equals that at the inlet, and we can consider the device is saturated. This starts from the second hour. If we can perform a cartridge after 2 hours, it will be start saturated and maybe it's not going to be as effective. So we have these different forces and mechanisms that make it happens absorption inside of the cartridge, the ionic bonds, the van der Waals forces, and hydrophobic bonds between the sorbent and the solute. So the configuration of the absorbents, it could be alone. If you see here, and if you see very near, you will see that here is the cartridge working, but there is nothing passing through this membrane because they are doing only hemoadsorption like this, even if this is only a hemodialysis machine. Also, we can make the hemodialysis that it works with the membrane and also the hemoadsorption cartridge and also with CRT. The Jaffron collection of HA has been very gratifying because now we are working for different kind of patients. The first hemoadsorption resins was launched on market in 1999 when I show you the first paper. And from there to now, we are making differences between the cartridge and they works for different indications. You will have chronic dialysis complications with HA 130, HA 230 for intoxication, and HA 330, also HA 380, that is a new one, from cytokine removal and sepsis. Also, we have combinations for patients with liver failure that calls DPMAS. It's a combination of BS 330 absorption resign from bilirubins, and also we have another different ones that I have never seen it, but I read it a lot of times about the DNA 230 from rheumatological and immunological disease. This is for recommended for different combinations. This other cartridge is recommended for drug-induced hepatitis, liver failure and complications such as hepatic encephalopathy, and can remove another intoxications. DPMAS is a combination of BS 330 and HA 332 that makes combination from absorbed bilirubin and bile acids, improving the symptoms of hyperbilirubinemia. Also, with this combination of HA 332, that is a disposable hemoperfusion cartridge, can be combined with DPMAS. That means double plasma molecular absorption system. And with this system, we can make a double absorption function that can remove bilirubin to quickly improve the symptoms of jaundice and remove inflammatory mediators such as tumoral necrosis factors alpha to maintain hemostasis as an effective treatment method for patients with liver failure accompanied by hyperbilirubinemia and hyperbiliacidemia. This picture is from Dr. Darío Jiménez in Ecuador. He is one of the first that performs in Fresenius technology, this combination. Also, in the nomenclature paper has been proposals about DP mass pressures and how it works with a blood flow in 150 and plasma flow in 10 to 30 milliliters per minute. And also ultrafiltration at this is not very well needed, but also after that the treatment finished, you can start ultrafiltration. Other combination is with, I already said about other extracorporeal supports. In ECMO, you can put the cartridge between the circuit. About the DNA, it's a column or cartridge with immunoadsorption about patient with lupus, and it has a high specificity about immunoreaction, specifically recognize and traps anti-DNA antibodies. So it's a different one. For me, the most I have performed and I have more experience is HA380. Also, HA380 and HA330 has been the most proposed for the cytokine removal. So they work in like this with the blood flow in that direction, and they take with these beds the large inflammatory molecules, and they stick it on it. Inside in the cartridge, there are absorption resins with neutral macropores that works like this and remove interleukin 1, 6, 8, and tumoral necrosis factor. And this is pearls have in the center of them porous that are neutral and high specific surface area and can absorb excessive inflammatory factors. So they can remove molecules that 10 to 60 kilodalton and are very effective when you use it to improve hemodynamics more than everything. For me, has been very interesting to see in patients with sepsis that after you have antibiotics and you try to control the cause and you have all that organic support, that makes a new possibility to make adjuvant therapies with immunomodulation and extracorporeal blood purification combination. So for us in AKI combination with sepsis, there is a lot of external and internal factors that makes a perfect storm, and maybe it could be interesting if we can control this part, the inflammatory response and the direct effect of pathogens to the AKI, to the kidney, sorry. So we have been through a lot to try to understand how hemoadsorption could be a good option to mitigate cytokine storm and also to improve the vasoplegic shock and the tissue hypoperfusion that is seen in sepsis. There are all these cartridge and therapies that has been proposal for this, and I think I have performed most of them except polymyxin B. The other I have used it. Talking about specifically about the liver, there are a lot of blood purification techniques, but also now we have DP mass, that this is the one. So we have been through all this and now we are on this and we have performed some. The absorption filters are a reality in Latin America, and we can perform in combination with other therapies. So in case we want to see what we have in one of my hospital, we can perform everything. Is from Mars to SPAD, the combination of continuous renal replacement therapy and plasma exchange alone, and DP mass with plasma exchange. So there are another indications. One is intoxications. The other is, this is new, the possibility to remove thrombotic and bleeding treatments or complications from anticoagulation. This is from Dr. David Ballesteros at Colombia, that he has been working with patients with intoxication with paraquat. He also made this case report about a patient. She was pregnant, and since she was in this intoxication with paraquat, and performs hemoadsorption with HI 230, and the patients went well. Also, he has this other case about the snake bite, and also performs the combination of this cartridge and improve the cytokine storm, and the patients goes better. So we have seen a lot of cases. Even if there is no clinical trial, we are seeing some response in patients that maybe have no future. For us, one of the most important part has been the educational program. The first step before you start hemoadsorption is training, because even if we as doctors knows how it works, the people who make it happen are nurses. So we need our specialists to get educational programs, training, and performance with a special nurse that maybe has before experience. So we keep training all time. If there is any time that we can do another or different therapy in all of my hospitals, we keep trying to teach everybody. So just for finishing, we are going to see two clinical cases that I had good results with hemoadsorption. She's a lady of 71 years old that arrives at hospital with dyspnea. She has breast cancer, radical mastectomy, radiotherapy, and Sjogren syndrome, treated with hydroxychloroquine. Also, she has hypertension, heart failure, and unspecified arrhythmia, and it's treated with licardipine, atenolol, and isosorbate. So she has a lot of pharmacy there. Then these patients begins 3 days before admission with sudden and progressive dyspnea, which evolves in hypoxemia of 80%. She was taken to the emergency room. She arrives with a respiratory rate of 40 and heart rate of 99, saturation of 80%, and blood pressure of 80/60. So she presents deterioration of his neurological status and presents also cardiac arrest, and we start CPR 2 cycles and makes also mechanical ventilation. Cardiology arrives and put a pacemaker and go to angiography, but there is nothing important there to change. And they start congestion heart failure treatment. So when she arrives to ICU, she was in anasarca with edema 4 points and a slow capillary flow. Also, we found in both extremities cellulitis or erysipelas at that moment. Antibiotics were started. Then a week later, it can be progressed from ventilator and start a pneumonia with a Staph aureus, and then we have an adjustment of antibiotics, and that don't works too much better. So they called infectology, and they said it was a septic shock and change again antibiotics. After 2 weeks, she was in anasarca again. Even if the heart failure treatment was intensified, so it was in fluid overload, refractory to diuretics, so the nephrology was take care. So after that, they decide to start a sled only with ultrafiltration, 4 sessions, but it has no improvement. So this, he decided to call me for a critical care nephrology consultation, and we start CRT, and we try to improve the ultrafiltration until we have a neutral balance. But in between all that day, 10 days after, we have also again another septic shock with again anasarca. So we decide to perform hemoadsorption. And we put 3 cartridges with 6 hours each one. And the first one was HA330, and then we have to change to HA380 to 8 hours, the other ones. So we start with these laboratories, and you can see, for me, the most important part is the vasopressors. You see the norepinephrine in 12 and vasopressin in 2. This is the first performance. Then 24 hours later, we have the norepinephrine in 4 and vasopressin was off. So the pictures are changed. The other one was 80. So also we can see the improvement from interleukin 6. And then finally, we have no pressure for the 3rd day, and the patient was better, and the patient go to the intermediate ICU. So patients gets better after 3 days of hemoadsorption, 2 continuous, and then we have a third after 1 day not performance. So we share this experience in different conferences. One was in the Jaffron Hemoadsorption International Summit, but also we performed this in Vicenza course. We have also some experience with the connection in ECMO, but not with the cartridge in the middle of the ECMO circuit. We put the machine of CRT because these patients needs also AKI support. So we put the cartridge in front of the membrane, so we perform everything. For the second case, we have a 50 years old lady with autoimmune hepatitis for 4 years diagnosis. She went under treatment with hydrocortisone, mycophenolate acid, and ursodeoxycholic acid with previous exacerbation under an incomplete liver transplant protocol. And 1 week prior to admission, presenting hypoxemia, asthenia, adenamia, accompanied by diffuse abdominal pain with an intensity 5 to 10, associated with food intake without any alleviating factors. The physical examination highlights she has mucocutaneous jaundice, mucocutaneous dehydration, encephalopathy, and ascites. So the auscultation was normal, but she has edema with biting 3 cross was noted in the lower extremities, and also for highlight, she has a 14.5 of total bilirubins with direct bilirubins to 10.2. So we have this patient also with the NIR 2.8, so a liver failure was diagnosis. It has a MELD score of 28, a childhood class C, and on the 5th day of hospitalization, it progression to grade 4 hepatic encephalopathy associated with AKI. So all the laboratory were worsening. We have an increase in creatinine and also in bilirubins, and we performed 3 sessions of DP mass on alternate days with TPE 2000 filters for plasma exchange and a combination of the cartridge of HA330 and BS330, this DP mass. So we perform the initiation of each session of more or less 6 hours with a plasma volume of 1.5 with times for DP mass in the first one, and then RTP. Also, we put a jugular catheter and performance CRT in CVVHDF, and the patient after the 3 sessions improvement were observed. You can see it here. So at the first session, from the first 6 hours before initiation, we have a total bilirubins 29, then we have 12. Then in the second session, we start in 26, and then we have 16. And the third session, that now we can see that the rebound is not that hard. We have 14 before, and then 9 from bilirubins, and also interleukin 6 was very dramatic performance of improvement. You can see it better here with the bilirubins, how move between time in the first hours, and then also in sessions, how the interleukin 6 makes this improvement. So we present this case in the Vicenza course this years, and it was very interesting for us. Just for finishing, maybe this is very science fiction, but this is the future or reality. The Hemoadsorção platform technology, the Future F20, launched in 2022, to performs only hemoadsorption without dialysis in these machines. Finally, and to take home message, blood purification techniques are part of the skills that critical care doctor must master. Currently, there are new blood purification techniques such as hemoadsorption. Sorbent can have an impact on the removal of medium and large solutes according to selectivity. And sepsis, systemic inflammatory response with cytokines release and poisoning are some of the indications for the use of hemoadsorption. Thank you for hearing me, and if you have any chance to answer our survey from SLAN, that we are looking for what is our situation in multi-organic support in Latin America, to see where we have stand now. Thank you, and I'm here to answer as much question as I can.
Thank you so much, Lília. On behalf of DaVita Brazil, I want to really extend our heartfelt thanks for your excellent talk today. I think you gave great insights of incredible value, and really appreciate your time and your expertise with us. Eu queria abrir para nossa audiência aqui, que sempre presente com a gente todo mês. Se vocês têm algumas perguntas ou comentários aqui sobre essa palestra sobre hemoadsorção, eu sei que é um tema que talvez para a gente aqui na DaVita Brasil seja algo novo, né? E aí é um método que está começando a ter um pouquinho mais de difusão aqui no Brasil, e a gente, né, tem um serviço hospitalar que também está começando a ter mais penetração, né, nas regiões aqui do país. Então, na medida que isso cresce, a hemoadsorção também ele tende a crescer também o nosso uso. Lília, I have a question regarding the training of staff. Are there any caveats to hemoadsorption training that's maybe different from what we do regularly for CRRT or hemodialysis in the ICU in general? Então, perguntei para ela se tem algum detalhe a mais em relação ao treinamento, principalmente de enfermeiras, né, da equipe, em relação ao que a gente faz habitualmente, né, com diálise contínua.
For us, is very important to have all the team there. We invite ICU nurses, hemodialysis nurses, ICU healthcare physicians, from critical care, pharmacists, and also the chief from the nurses. I think they are the most important one, because sometimes they didn't understand why we need a special training in this. So not every nurse can perform. Most of them are the nurses in ICU that works with CRT because they understand better. So not everybody can do it. So for us, it has been every time we start a new treatment, we start with the training. We cannot perform any treatment if we don't have the training from the nurses. But sometimes we have the specialist here. Like as you've seen, here it comes a lot, Emilve from Colombia here to Mexico. So sometimes we have the lucky to have her at the moment that we have a patient. So we teach nurses in the middle of the treatment, but most of the time we do it before. And we try to make a consensus between the time and prepare like a different conference talks about how it works, physiology and mechanically, and then we make this hands-on like a workshop for the nurses. For the nurses, most of them, if I have the fellows to be there, is better, because when the nurses put it in the middle of the night, the fellows go there and help them. also to understand better how it works.
Excellent, excellent. Então, a doutora Lília explicou aqui sobre a importância, né, de treinar, né, a enfermeira, principalmente a enfermeira da UTI, né, que tem um papel importante, mas não só enfermagem, como também médicos, né, os intensivistas também têm que estar presentes, né, saber direitinho as indicações, né, o treinamento é importante ter, né, aulas antes, né, mas durante também o tratamento faz a diferença também, certo? Então, é importante isso, e isso é uma coisa que a gente enfatiza bastante no nosso serviço hospitalar da vida. O Marcelo Alexandrino faz uma pergunta, Marcelo Alexandrino here wants to know if in your hospital, you mentioned that you work at 2 sites, right? So he's asking like the main form of like resources. Is it you mentioned like at a private practice and also like a government related, like public hospital, right?
For us in the private hospital is easier to perform like a DP mass because TPE and everything is more at the hospital at that moment. In the university hospital, that is a public hospital, we have to make a lot of bureaucratic tramits to have everything there. But there are sometimes that magic happens and we have everything. I think we have all Latin American countries have these problems with the government and social medicine. So also in our university hospital, we have a lot of people that make us donations. So for us, sometimes if I have a patient in a private hospital and then they don't use any cartridge, they donate to me, but they say that they want me to use it in the hospital with people who have no money. So we move that from the other hospital. So because of that, we have been making some experiences, and then we teach and shows to healthcare and administration how it works and improves sometimes hemodynamics and saves times also and money, because if you spend less time in ICU, you spend less money at the end. So we are working on it, and they are now are more sensible about this and it working better.
Então, basicamente, mesma situação no Brasil, né? Assim, no serviço privado tem mais facilidade, mas ao mesmo tempo ela tem que sempre mostrar, né, uma relação de custo-efetividade. Então, ela tem mostrado com os casos, com a casuística dela, né? Faz uma análise mostrando o tempo que ela economiza do paciente estando internado. Mas no público é a mesma coisa que a gente aqui, né? A gente tem que passar por burocracia, às vezes contar com doações, então é a mágica, né? Como a doutora Lília falou, que faz acontecer. So you're catching on the Portuguese, right?
Yeah.
Wonderful. Lília, she's complimenting you on your excellent lecture. And she also has a question specifically about the costs of a therapy for each session. Can you give us like a broad highlighted view of costs?
Maybe I can make a comment about conception, but I think Ricardo can answer better than me about the costs. But for us has been a very nice discover to see that we spend less than with other therapies. Like there are therapies from another industries that are too expensive because of the machine, the circuit, albumin, and everything you need. It's too expensive, and also we spend 2 or 3 hours only for the connection, and then you start the treatment, and the treatment is very unstable sometimes. And for us, it works better, make the connection all together in one platform. And also you have to spend less albumin or cartridge or time or people even, because you don't need 2 or 3 persons to take care of everything. So it's better and it's cheaper than the other ones. But I don't know, here in Mexico is like I will say that maybe 30% less from other therapies in case of DPMAS. And also the HA380 is less expensive from the other one, like I think like a half or less, maybe.
Uhum. Então, de uma forma geral, tem algumas coisas que implicam aí no custo, né? O circuito, a necessidade de albumina, a necessidade de colocar, né, o cartucho, mais a hemodiálise. De uma forma geral, em torno de 30% a mais aí do que seria com um tratamento convencional, mais ou menos assim. Ricardo, você quer fazer algum comentário também assim sobre essa questão de custos? Você pode se apresentar aqui para o público e se você tiver algum comentário também sobre isso. Tá me ouvindo, Ricardo?
Tô. Boa noite a todos. Toda a Lília. Sou Ricardo da Jeffra. Na verdade, o produto já está testando no Brasil, também usou na HC. HC para a criança tem um bom resultado. Também o doutor, depois de vários doutores, o doutor Thiago Reis, ele testou no Clínico, também a Fênix. A Fênix também precisa Nefrologia, algumas clínicas clínicos também testaram. A gente está programando para fazer alguns estudos, por exemplo, com o doutor de cirurgia cardíaca, de doutor Juan Messejana, de Messejana, Hospital de Messejana também tem estudo. A gente também está fazendo projeto com o doutor de Fábio Radeni de Incor, para cirurgia cardíaca, porque a gente também acha no Brasil o custo para agudo é um pouco difícil, na verdade, como a doutora e o doutor falou. Público é muito bem difícil. Privado deve ter alguns hospitais que têm condição para pagar, por exemplo, Einstein, Sírio-Libanês, PP, esses hospitais. A gente está fazendo alguns testes, tanto agudo quanto crônico, já tem alguns resultados preliminares, resultados são bons, mas ainda precisa mais evidências, alguns estudos para mostrar o convênio, assim.
Joia.
Mas sobre o custo, porque a gente tem dois distributores, um distribuidor que fica em São Paulo, que distribui no sul, sudeste, tem outro distribuidor em Salvador, Bahia, que oferece para as regiões norte e nordeste. Então, se os doutores querem conhecer com eles, querem conhecer, querem fazer, como a doutora falou, para o treinamento, pode falar com eles, eles têm a técnica especialista para fazer treinamento, como funciona na máquina, conectar com as máquinas diferentes no mercado, assim, não tem problema.
Joia. Obrigado aí, Ricardo.
Nada, doutor.
Eduardo, eu estou vendo sua mão levantada aí. Tem uma pergunta?
Oi, Marcelo. Boa noite a todos, meus parabéns pela palestra, professora Lília. Parabéns, prazer em conhecê-la. Pleasure to meet you. Hey? Você tem experiência em miastenia graves ou em síndrome hemolítica urêmica, essas indicações? Tem? Como é que está, Marcelo? Eu peguei no meio da palestra, não sei se foi comentado alguma coisa a respeito do uso em miastenia graves.
Miastenia, eu acho que não. Do you understand the question, Lília? Yeah.
I think so. I think he is asking for the experience in myasthenia gravis and syndrome hemolítico urémico. And I don't have any experience on it, but we know that plasma exchange is a treatment in some of them. And for sure, if there is a rationale about inflammation, cytokines, or combination of, it could be a good performance for me. We have been doing a lot of things out of label with patients without any, because we say the patient didn't read the book. The patients go out from from everything we have, and they are out of clinical trials. They will never been in any clinical trial because they are too critically ill. So sometimes we perform a lot of things together that there is no evidence of, but it works sometimes. And we make combinations from plasma exchange with hemoadsorption, make combination with hemoadsorption and liver support. And then even in the same catheter, we have been blown mind with make some parallel combinations also. So we are trying to find the sangrial, as we say here. But I will say that in syndrome hemolítico urémico, we have been doing some kind of things and combinations, plasma exchange and some hemoadsorption, not with very good results, but with the same rationale.
Mm-hmm. Yeah, and also there's a question from the chat, which is the main indication currently for
Hemoadsorption.
Yep.
For me, what I have seen better is patient with hepatic failure. The liver failure and DP, the combination with plasma exchange and DP mass for me has been the greatest finding, that because I performs a lot multi-organ support. In my hospital, we have everything, ECMO, mass, plasma exchange, and everything. We can do everything. For me, DP mass is one of the best, without a doubt. And we also performs a lot of HA 380 for sepsis, but at the beginning. And we have done some difference also for patients with other kind of inflammation like pancreatitis.
Yeah. Wonderful. Let me see if there are any more raised hands. I think we just passed the top of the hour, so I think it's a good time to call it a day. So thank you so much, Lília, again, for your excellent presentation. We're very delighted. We were very delighted to have you here, and hopefully we can catch up here in Salvador. And
Definitely.
looking forward to see your talk here as well. So thank you.
Thank you. Thank you.
All right.
Nice afternoon.
All right.
Thank you,
Take care. A todos aí, muito obrigado aí mais uma vez aí por vocês estarem com a gente, né? É muito bom estar todo mês aí com vocês, vendo seus comentários, suas perguntas. No mês que vem a gente já está organizando falar sobre, tem uma palestra sobre intercorrências na sala de diálise e também de hipertensão no paciente doente renal crônico em hemodiálise também. Isso em outubro. Em novembro também a gente vai ter uma outra sessão internacional que a gente vai chamar de um simpósio DaVita Brasil com o pessoal do estudo DOPS dos Estados Unidos. Então a gente vai trazer dois pesquisadores aí internacionais que vão falar muito sobre volume, né? Diurese residual, UF, né, em relação à sobrevida no paciente que faz hemodiálise também. Então, esses 2 meses aí vão ser bem interessantes. E semana que vem tem um congresso aqui em Salvador, né? Então, Lília vai estar. Eu espero ver muitos de vocês aqui na minha cidade, Salvador, tá joia? Então, se vocês me encontrarem aí, dá um oi aí, a gente vai batendo um papo, tá joia? Ótima noite aí para vocês. E até mês que vem. Até semana que vem, para alguns, viu? Um abraço.
Abraço.
Abraço. Tá bem.
Abraço. Tchau, tchau.